Hi everybody, welcome to my domain modelling project for assignment 1. My topic covers intravenous iron infusions and an overview of a possible decision support system. Basically, we're going to cover a little bit of background information on the problem, the concept of my domain, and the rationale behind its development. So what is the problem with intravenous iron replacement? Currently, there are 4 preparations of intravenous iron licensed for use in New Zealand. Iron polymaltose, iron sucrose, ferric carboxymaltose, and iron dextran. Of the 4 available, 3 could be used within a district health board or hospital setting, and 2 are funded for use within the community or GP setting. Prescribing can involve complex clinical factors and dose calculations. Anemia occurs when you have a decreased level of hemoglobin in your red blood cells. Hemoglobin is the protein responsible for carrying oxygen to your tissues, and your body needs iron to make hemoglobin. So if you have iron deficiency anemia, which is the most common form of anemia, your body doesn't have enough of the iron mineral. If there isn't enough iron in your bloodstream, the rest of your body can't get the amount of oxygen it needs. The symptoms of moderate to severe iron deficiency anemia may include general fatigue, weakness, pale skin, shortness of breath, dizziness, strange cravings to eat items that aren't food such as dirt, ice or clay, a tingling or crawling feeling in the legs, tongue swelling or soreness, cold hands and feet, fast or irregular heartbeat, brittle nails, and headaches. There is clear evidence to support prompt treatment in all patients with iron deficiency anemia because it is known that treatment improves quality of life and physical condition, as well as alleviate fatigue and cognitive deficit. While dietary replacement may be used for very mild cases, often oral iron supplementation is required. However, up to 70% of patients who are prescribed oral iron report gastrointestinal side effects and therefore may not continue adequate treatment. Intravenous iron is generally reserved for use when oral therapy is unsuccessful because the patient cannot tolerate oral iron or does not take it reliably, if there is continuing blood loss, or in malabsorption. With the exception of patients with severe renal failure receiving hemodialysis, intravenous iron does not actually produce a faster hemoglobin response than oral iron, provided that the oral iron preparation is taken reliably and absorbed adequately. Be administered inside the hospital setting are iron polymaltose, iron sucrose, and ferric carboxymaltose. But there is large cost variation between the IV preparations, as well as clinical limitations in both administration and use. I believe that iron infusion decision support would be useful because of a number of factors. The dose calculation can be complex, which I'll further review in my later slides. There is risk of using the wrong formulation. Protocols involved are often lengthy and time-consuming for the prescriber, and it may also contribute to reducing the risk of medication-related harm and resource inefficiency in terms of both time and cost. To get my head around my goal, I did some mapping in SNOMED terms to kind of link the concepts. This is a pretty basic overview to ensure that I could support the indexing and mapping for an interoperable system. This allowed me to translate from some of the clinical concepts I use every day into my idea of a domain model. So first up, we have a patient admitted to hospital, in which the patient would be worked up with a clinical history, differential diagnosis, and an evaluation. At that point, they may consider running bloods for anemia. So we'd be looking for iron deficiency anemia. From that, we would then identify if there were any risks or considerations in treatment that may require dose adjustments before we were to prescribe the iron infusion. These would be to consider things like their renal function, pregnancy, what their body weight is, and if they've had any recent transfusions. If we were happy with these terms, then we would consider prescribing the iron. This is what I've come up with for a domain model. Now note, there are lots of other potential inputs and outputs. However, I really wanted to simplify this to the clinical issue of my domain, keeping it in general principles and terms to explain the concept at a level that could be understood by both clinical and non-clinical members of this class. So hopefully it's pitched about right, and I'm going to further explain the points in the next few slides. Looking at the input side of my domain model, I've tried to keep it simple. I looked at the limitations for the formula and calculation of iron infusions, and learnt from previous experience where I've had a far too ambitious scope, and decided the criteria should be iron deficiency anemia diagnosis requiring an infusion. The rationale is that other clinical decisions are needed if we were treating non-iron deficiency anemia. The second would be adult patients. I want to exclude pediatrics initially because they require a different set of calculations. And then the special considerations that may affect the calculation. For example, renal function. So dialysis patients have different requirements as they may need other medications with their iron, so their dosing is quite different. So this would not be a suitable decision support for them. And pregnancy. At this stage, patients who are pregnant would be a screening fail as they require a different hemoglobin target to our standard adult patients. And we'd need to consider pregnancy as a safety consideration as well as the adjustment in the calculation. I haven't completely excluded them from my domain as it is a vulnerable area in which decision support would be beneficial, but I really want to make sure I get the basics right first. Now I promised a calculation, so here it is. For those that don't practice clinically, we use this equation called Ganzoni to give us an idea of how much iron is required to completely replace the deficit for our patient. It's based on a blood test, a patient's weight, their hemoglobin target, and a correction factor, which is related to the iron content of the hemoglobin and the blood volume, as well as replacing the iron stores. This overview already gives a little insight into why modelling and a decision support system would be useful in iron infusion calculations. After our calculation, we have an idea of what the output might be, and this could help indicate the options for prescribing. I've put in some preparations at this point to highlight that we might administer a different preparation based on what our dose output is. Additionally, there are some other considerations to do with rate, depending on which type of iron we decided to use. I've used examples here only because I think it better highlights the concept of my domain model. When I consider this model, my target would be designed for prescribers, whether it's a doctor, a nurse, or a pharmacist, as there would still be a degree of clinical decision. Ideally, I'd want to maintain the semantics so that I could integrate this into software or modelling tools. And dose rounding would be really useful from both a practical and cost perspective. For use in a live healthcare system, testing and validation would need to be performed comparing it to current practice, which would either be prescribing via written guidelines or screening by a clinical pharmacist. The limitations include a really tightly defined scope is required to ensure that it is accurate. I have designed it for inpatient hospital use, and we may need to adjust it based on variations in regional guidelines. And ultimately, there would still be prescriber clinical decision involved. Here's a slide summarising some of the resources, and thanks to the Awkward Yeti for permission to use some of their cartoons to illustrate my concept and hopefully provide a little bit of comic relief. Thank you.